Hi, this is Brian Kim. I want to share with you episode 231 in the Best Way to Do Cataract Surgery series. And again, the title of this is not to say this is the best way, but to get you to think critically of your technique, to hone and refine your technique so that you can be the very best for your patient. And so this is a patient with a fairly big pupil, but you can see that the eyelids are rather floppy. And I'm going to use a small speculum for this case. You can see that the eyelid is retracting a little bit funny. There's a floppy eyelid here, and I'm not getting the best retraction. And you can see that the lid is still staying flipped over in this floppy eyelid patient. So I'm switching the standard Lieberman to this small blade speculum. And so this is the small blade speculum E1-271. And it's really a great little tool for this situation. Again, a Lieberman speculum opens the eyelids in a rectangular configuration, but the cool thing about this small speculum, it really opens and retracts the lids in a diamond-shaped configuration. You can see there's so much more exposure of the eye superiorly and inferiorly. Again, comparing it to the Lieberman, look at this beautiful retraction. I can see so much more of the sclera and the conjunctiva superiorly and inferiorly with this small speculum. This is a corneal marker which will help me to center and size the rexus. And then using the cotton tip to steady the eye, I'm turning the eye towards the left. And I'm making my right side incision, making sure I'm parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. You can see the conjunctivochalasis, which is a reflection of the floppy eyelid. Injecting some intracameral epinephrine and then some dispersive viscoelastic to coat the corneal endothelium and to flatten the anterior capsule. And this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and then when I'm ready to enter, I turn the eye towards me with the cannula and then enter. These are the sharp tip Moria micro rexus forceps. I puncture the center, pull down towards me, nudge the tear towards the right to create a flap, grabbing the right side of the tear, going around circumferentially, grabbing and re-grabbing. I have very little worry about radialization forces with this forceps. I have very good control. I'm able to follow the corneal mark that I made. I'm using the cannula in this instance to control the eye because sometimes the patient wants to move, and I've noticed more and more I like to have a two-handed approach when I'm doing my rexus to give me that added control. Finishing off the rexus, burp some viscoelastic out. And this is the capsule fornix hydrodissection technique. I place the cannula under the rexus edge contra-incisionally, point the tip down, jiggle a little bit, get a nice wave, lift the lens up with the cannula, decompressing the bag, sweeping under the rexus edge. And as you can see, as I do this, despite all of my efforts, getting good hydrodissection, lifting the lens up, you can just see that the bag and the lens are still stuck a little bit together, but I'm not going to go crazy. I still can chop the lens and disassemble the lens without trouble. And once I get some pieces out, I'll be able to more efficiently and gently rotate the lens pieces. Irrigating the surface of the eye. Lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma. Removing the surface epinuclear material. As I remove it, you can see there's quite a bit of jiggling, which does suggest maybe there's some zonular laxity. Placing the chopper under the rexus edge contra-incisionally, the phaco tip vertically sub-incisionally, crushing the lens with flanking forces, that's the double chop. Placing the chopper around the right heminucleus, hooking the peripheral lens, and crushing it against the phaco tip, which is deep in the trough, and that is the cross chop. Getting around the first quadrant with the instruments, crushing the lens into smaller pieces, and then emulsifying the lens pieces. Gently separating that second quadrant from the rest of the lens, and then placing the chopper around the lens, crushing it against the phaco tip, crushing it once more time with opposing forces, and emulsifying the lens pieces. Hooking the remainder of that lens piece up with the chopper and pulling it out of the bag. And then now that that heminucleus is gone, I'm able to rotate the second heminucleus very nicely away from me, placing the chopper under the rexus edge contra-incisionally, pulling it centrally toward the phaco tip, which fractures the lens very easily using flanking forces. And that is another cross-chop maneuver, essentially, grabbing that third quadrant up, crushing the lens into smaller and smaller pieces, and then emulsifying it. Nudging that fourth quadrant around, getting around the lens with the chopper, flanking it, and then crushing it with the instruments, crushing it into smaller pieces and emulsifying the lens pieces, hooking the last fragment with the chopper, pulling it out of the bag, crushing it into smaller pieces, and then emulsifying the lens piece. Using some vacuum to grab the epinucleus, and that is removal of the lens. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. I always start sub-incisionally, peeling from anterior to posterior, peeling the cortex. In this way, provides the cleanest way to remove the cortex, and it reduces the chances of having those fine cortical wisps. Very easy removal of the cortex in this case. Switching to polish mode, polishing under the rexus edge. And polish mode is really nice because it's lower flow settings, and so you can't accidentally grab the zonules and cause any damage. I haven't had any issues with posterior capsule rupture or damaging the capsular bag with this polymer tip and on this setting. Polishing the posterior capsule very gently to remove any fine cortical remnants. And again, if you didn't have the polymer tip and you had a metal tip, I would be much more nervous about doing this maneuver. With this polymer tip, I don't have any worries, and I'm able to more confidently and effectively clean the bag. Pulsing BSS into the subincisional capsule fornix. Disengaging the irrigation, and then pushing cohesive viscoelastic to fill the bag. Switching to the sweeper, able to polish under the rexus edge on the left side, as well as some of the subincisional capsule. Switching and then polishing on the right side, switching incisions, and doing the same thing. The sweeper is really nice. It's a very easy way and a controlled way to clean those lens epithelial cells besides using the INA handpiece. This is a single piece of acrylic lens that's going into the capsular bag. Go in with irrigation off, activate irrigation, disengaging the haptics off the optic. Getting underneath the lens, tilting it and rotating it 90 degrees, removing all the viscoelastic from within the bag. Repositing the optic back down, polishing under the rexus edge, removing any fine lens epithelial cells. Rotating the lens, removing the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a patient who had floppy eyelids. You can see the unusual stretching of the lid, and as I was stretching the lid, you can see the conjunctival side, the palpebral conjunctiva prolapsing anteriorly. Again, with the Lieberman-style speculum, it opens the lids in a rectangular configuration. With this small speculum, I'm able to retract in more of a diamond-shaped configuration. Therefore, the apex of the retraction is superior and inferior. I have so much more exposure of the eye, superiorly and inferiorly. And when you think about it, I'm not really retracting it really strongly. All I'm doing is I'm not retracting so widely. And because, again, it's not retracting in a rectangular configuration, it's more like a diamond shape, I'm able to apply really not terrible amount of retracting force and get so much more exposure. And why is this so important? Because we already know this. The temporal side has easy access because that's where the palpebral fissure is. What you really need better access is really superiorly and inferiorly. And this does so much better than the standard Lieberman speculum. And whoever came up with this speculum is really just brilliant, just from a concept point of view, an anatomy point of view, this is really so much easier in my experience with these kind of cases, not just floppy eyelids, but also kind of small, tight orbits or deep set orbits. With using this small speculum is an advantage compared to any of the other specula I've used. So I hope this was helpful to you, and I thank you for your attention.